and this is an East Carolina accent, but anyway, so the guy is an ortho trauma guy. They currently have New Shield in there, and they're going to allow him to use it case by case initially. And I'm working through the formulary process right now.
All right, yeah. So I mean, to just speak to that real quick off the gate, right? New Shield's an incredibly high, or it's an incredibly expensive product in a surgical setting. I mean, I think you guys have enough experience in the surgical space to know that price kind of dictates everything. New Shield is not some technologically advanced device. It's an amniotic membrane, just like what we're talking about, with Revigen. So I think the biggest selling point there is going to be price. From a clinical perspective, the results are going to be, maybe marginally different. I would doubt it. Tim's graft I know where it's made. I know the guys that make it. I know how he processes it. Tim's graft is absolutely fantastic. We compete against New Shield. And just to give you guys a little bit of background. So I own a distributorship that we sell in 30 states. As of yesterday, I've got 74 guys across those 30 states. So we're on a very big book of business and sell into many different markets. So New Shield's definitely something that we've sold against for a long time. And the biggest differentiator is going to be handling, right? New Shield is not a surgical graft. New Shield was designed for wound care. So it's going to handle like a wound care graft. And what I mean by that, right, is in a chronic open wound setting, you don't need it to have any kind of particular handling properties or anything like that, right? You're just dropping a piece of amnion down onto an exposed wound. So if you take that image, I mean, ortho trauma, sure, you're going to be working in an open setting. What I'll tell you is, I've seen it many times with my Medix product, AmnioFix, and I'm an ortho trauma trained guy. That's where I came from. I was a striker for a while. Ortho trauma, they're all about speed. They want products that are going to work, but they really don't care about marginal differences in clinical efficacy. They care about price point, so the hospital doesn't, bitch at them 24/7. And they care about, the speed in which they could get these procedures done. So go in there against New Shield. Look, your clinical results are going to be exactly the same. Product's going to handle a little bit quicker, so you're not going to have to mess around with it, right? I mean, these grafts should go down in 30 seconds or less. Stuff like AmnioFix and New Shield, once it starts crumbling up, right? Once it comes out of the packet, if your doctor's gloves aren't completely dry with either of those products, it's gonna start wadding up to the glove. It's gonna tear. It's gonna be a mess for them to try and place surgically. So go in there. You can absolutely beat them on price, and you absolutely have a superior graft that handles better than what New Shield is. Does that make sense?
Yeah. Yeah, so Malcolm again, and just touching base. So Cindy is my DoD VA guru. She has relationships better than anybody that you can imagine. But getting these people to understand, she's gone from a nurse that literally, breaks bread with them, breaks breakfast, lunch, dinner all the time, to now she's a sales rep, right? And they kind of look at her with arm's length. The doctors love her. But a lot of these guys, and Cindy, correct me if I'm wrong, they weren't really using many things in the OR. So where we are right now, Jerry, is that we have it in wound care. They're doing it in clinic. The doctors are becoming believers, but every other specialty under that big umbrella there, they're not familiar with how to use it in the OR, right? So I know, like you said, the handling differences, all that jazz. We've gone to urology. We're going to be talking to some derms coming in.
Well, so hold on. Let me just preface. That entire thing that I just spoke about is specific to an ortho trauma setting.
Oh, I got you.
Urology, general surgery, GYN, colorectal, that is a very, very, very different talk track. So I was just giving you guys, based off of Malcolm's point, around this ortho trauma that's using New Shield, I was just trying to give you some cross-selling points there. But what I said is not applicable in any way into general surgical procedure.
All right.
So let's just hit on the tendons. Let's just get through kind of some of the ortho stuff, and then we'll really do a deep dive into amnion. So Cindy, you brought up like semi-Ts, I believe, something like that, and you wanted to talk irradiated versus non-irradiated, correct?
Yes, correct.
All right, so super, super simple. And this is very, very particular for many orthos. Biggest difference between an irradiated graft and a non-irradiated graft is an irradiated graft is going to have a weaker tensile strength than a non-irradiated graft. Meaning, your doctor throws a suture through it. If he throws some kind of wire through it, how much force can he pull on that thing before the suture is going to rip out of the tendon?
Okay.
That amount of force drastically increases with a non-irradiated tendon versus a gamma irradiated tendon. Okay, so there's different types of radiation out there. Gamma is the standard of care, and that cooks tissue at about 15 kilograms. Anything above 10 kilograms is going to start wiping out the cytokines and growth factors important from an allograft tissue. So that's where your conversation with your orthos is going to be irradiated versus non-irradiated, right? If you're treating a young patient ACL injury, right? Doc 9.9 out of 10 times is going to ask for a non-irradiated graft in that setting, right? It's a younger patient. The longevity of that graft needs to be much, much higher than in an elderly patient, right? And there's some other considerations that they take into account there, right? Comorbidities and other types of issues that may prevent an allograft from taking, right? From when you start talking rejection versus acceptance, those comorbidities come into play. But in general, when you're selling a graft, right? And this will happen all the time with our sports med guys. The doc will just shoot them a text, hey, 22-year-old PCL, ACL patient, I need a graft. And sometimes they won't specify. So kind of there's a consulting role to that as well, right? Learning that physician, learning what's important to him. But in general, you're talking about a patient 50 years of age or younger. A non-irradiated variant of a graft is going to be preferred versus an irradiated variant.
Correct. Now, especially in the DoD system, they do want those younger donor grafts.
Yeah. Yeah. And I'll tell you, donor age is very, very tricky. Unfortunately, fortunately, we're kind of beholden to nature, right? So you're going to get a lot of requests for specific size grafts from specific age donors that there's just no company in the country that will be able to fulfill. But there's a consulting role, when you get that text from the doc, hey, I've got a 22-year-old ACL with diabetes coming in, what do I do? And you will get that question. So that's the biggest difference, right? If you're talking about a 50-year-old or younger, relatively healthy, not a bunch of comorbidities, but relatively healthy. A non-irradiated variant or an irradiated variant without gamma is what your preferred modality would be there. And then your elderly patient, right? The Achilles that snaps off after granny stepped off a curve and rolled her ankle. That's a patient you do more often than not, the physician's not going to want to waste a preferred graft on an elderly patient that, is not going to be running again. She's not going to be heavily active, right? We're just trying to restore her function so that she can walk. Does all that make sense?
It does. So when looking at our grafts online, the PESCO, PASCO, is that the process of the non-irradiation?
Yes.
Is that the CO2?
Yep. So PASCO is a non-irradiated variant of sterilization. Yep. Or of processing, not sterilization.
And we don't do currently distal tibs, or we don't have distal tibs.
Like distal, what do you mean? Are you talking tendon or are you talking bone?
So we had a surgeon, Dr. Goodlet, and he was asking about distal tibialis tendons.
Tibialis,
yeah.
So we got anterior and posterior tibialis tendons. I guess if he's asking distal, he could be talking about an IA length.
Hold on, I had made some notes too. I want to pull up my text messages that I had on a prior thread with this provider. Hold on 1 second. And remember what he said.
I mean, he could be talking about the length of it. That's the only, but I mean, as far as Tim, you ever hear that?
Oh, I know what it is. I know what it is. So, hold on 1 second. So he wanted a fresh distal tibia allograft. And he wanted it fresh, and it was because he needed the viable living cartilage cells to perform a cartilage restoration surgery.
Yeah, so he wanted a true
fresh frozen
distal third portion of a tibia.
Yes, sir.
Yeah, so he wanted that whole cut. We can definitely get those. I would say, with a request like that, get that over to Tim as quick as possible.
Okay.
And then I can help, I could definitely help
We'd have
source.
to, we wouldn't keep those on hand, but our manufacturers would probably have them and we could source them. But that would be that'd be like a special thing that we would order for that case.
Yeah, you're not going to get that
Okay.
request very often, Cindy.
Okay.
Yeah.
All right. Cindy, do you have any other questions on the tendon front of things? Does all that make sense?
Yes, I think on some of the grafts too, when they get them for LifeNet, Arthrex, other places, they have to use like a tray that comes with the grafts. I think for some of the ACLs, don't they have like cutting trays?
Mm-hmm. Yep, they have
Do we
cutting guides.
offer anything along with our grafts? Because I know with Arthrex, if you don't get the graft from them, they will not supply that. So then it's an extra cost to the facility.
Yeah, so I was an Arthrex guy as well.
Okay.
So I was a regional director for them for trauma and biologics. Arthrex is really shitty with that. I'll tell you that those cutting guides, those suture guides, you can literally use 2 towel clips and achieve the same exact thing without spending an additional $1,500 on an expensive Arthrex graft.
Okay.
So,
Well, I mean, that's good to know.
yeah, I mean, those types of sets and those trays and those instrument, they're starting to really catch on. And there's a bunch of smaller sports med companies that are kind of creating those kits and including them. But from an actual application standpoint, I mean, that might save 5 seconds, 10 seconds. Yeah, and you could achieve the same exact thing with a towel clip just on your Mayo stand. So definitely not a deterrent. If a doctor is a big Arthrex guy, he's going to give you shit about it, and he might not want to convert just because of it. But Arthrex is really, really good at wrapping their arms around sports med guys and kind of bringing them into the fold. So if you run into a doctor like that that's just hell bent on having these guides and stuff, don't spin your wheels there. It's not worth it. Your ROI, you'll have much higher ROI spent in different specialties. Now,
I just know that sometimes they can't provide graft. They third party their grafts. They're going through LifeNet, MTF, whoever it may be. And if they want these cutting guides, I just wanted to be able to speak to that if we did have them or not.
Yeah, we don't.
Okay.
But we, and also just kind of like Jerry's speaking to, that of all the things that we're talking about, the tendon business is the lowest margin, hardest to acquire.
Yeah.
Product line.
Yeah,
but that's okay. We'll do it. We'll service them, and we sell quite a few of them, so it's not a big deal. But like Jerry's saying, if it's a really big uphill battle, your time is, it's sort of, you're kind of looking for the customers that don't need those bells and whistles. Yeah.
Okay.
Yeah, and these accounts, once you get like a good sports med doc that's used a couple of your tendons with you in the room, more often than not, these situations kind of turn into mailbox money, right? You get a text from his surgical coordinator or the OR manager with specifics for the graft. You get the graft there and you don't even show up, right? So very low margin book of business, could be cool book of business, but it's definitely a headache as well. So just
got it.
Yeah. All right. You guys want to talk surgical amnion first or wound care amnion?
Surgical.
Yeah, I say surgical as well too.
Surgical.
Cool. All right. So surgical amnion into those specialties, Matt, that you were kind of alluding to. So the GYN, urology, colorectal, general surgery, bariatric surgery, that space with amniotic membranes is heavily untapped. It's very much a blue ocean market currently. And what I mean by that is there's never been an amniotic company focused on surgical, right? You look at the behemoths in the amniotic membrane space, the Mimetics, the Organogenesises, the Integras of the world, they all designed their amnion for wound care first, and then kind of started trying to adapt into the surgical space. So the engineering behind these grafts is not ideal for any type of minimally invasive or robotic surgical setting. What I'll tell you is the product that you guys have is, I know how it's made. I know how it handles. It's a fantastic graft that can be used through a trocar or cannula, whatever you want to call it, very, very easily. Introduced through an 8 millimeter or smaller trocar, and then unfold perfectly in vivo without any issues. It's not going to clump up. It's not going to tear. It's not going to become mucousy and difficult to handle once it's introduced. Right. So there's a lot of competitive advantages of the product that you have comparatively to the other amniotic membranes out there. And you're going to see them, right? AmnioFix is on pretty much every hospital shelf across the country. MiMedx has just been the biggest name of the game. They've been around for the longest. They've done really fantastic job at national contracting, right? So all their product is on your hospital shelf. That product that's sitting there is probably about to expire because for the last 3 to 4 years, surgeons have really pushed away from it because it's, you know, from a clinical efficacy standpoint, it doesn't work. And from a handling standpoint, it pisses everybody off, right? So it adds more frustration than solves solutions in the OR. So AmnioFix, it's a single layer amnion, single layer chorion product. What we have through Revigen is a dual layer, 100% amniotic membrane. That's very critically important. And, you know, you look at PureApply from Organogenesis and some other products in the market, their engineering is the exact same thing, right? So it's an amnion chorion based product, not a dual amnion. Most companies produce amnion chorion products for a couple of main reasons. First off, it's much, much, much cheaper to produce. Do you guys understand how amnion and chorion are related? Like, do you know where it comes from and all that?
It'd be good. Just a quick refresher if you don't mind.
Yeah, perfect. So you look at the placental membrane, right? The placental sac. It's comprised of 3 different layers, okay? So the outermost layer is a chorionic layer. That outermost layer is there and specifically designed to protect mom from the parasitic baby inside her, okay? Chorion in and of itself it's completely maternal. Its only role is to protect mom. It has nothing to do with regenerating new cells for baby. Okay, and then in between amnion and chorion, there's an interosseous membrane. It's a stromal layer. It's very tacky, and it keeps the chorionic layer attached to the amniotic layer, kind of like a sticker. Then that innermost layer is your amniotic membrane. Okay, that amniotic membrane has 0 maternal antigens connected to it. We cannot market it as a stem cell, but at the basic level of what amnion is it is a stem cell, right? It allows the baby to form whatever it needs to form to grow into a functioning human prior to delivery. So if you look at it through that scope, right? If what we're doing with the Revigen product, right, is we're removing that chorionic layer or retaining that stromal layer. And then what you're doing is folding over the amnion onto that stromal layer, causing the 2 to stick together. And now you have 2 pieces of amnion instead of a chorion amnion product. By doing that, we're removing the type 2 antigens that have many, many, many reported adverse events against them to the FDA, right? So you guys can be very, very proud to market this and talk about this with your providers. Revigen and its suppliers have never had an adverse event ever reported to the FDA against the companies. That's very, very critically important. MiMedx has over 79 adverse events reported against them. MiMedx is being currently sued by the FDA and the FTC for false marketing related to some of its products and related to some of its clinical claims. But that clinical differentiation, right? Removing those type 2 antigens, that's massively important, right? So there's a huge selling point. Now let's go back to that, like kind of what we were talking about when we were talking NuShield, right? The handling, the ability for these grafts to be folded up and introduced in a minimally invasive setting is very unique to what we're doing. There's no other companies out there really that have a graft that can be introduced as user-friendly as the products that you have at your disposal. So again, dual layer, 100% amnion. It's gonna be much safer for your patient. Your provider should feel a lot more comfortable about that. You can't say it's a do no harm product, but guys, as sales reps, you can feel very, very comfortable about selling this stuff. It's not going to harm your patient. Let's kind of get into general surgery and why. Let's just talk why amnion. Why is it being used in these settings? some of the biggest issues in the general surgical space, whether that's colorectal, esophageal, urological, there's a high incidence of leak. And there are currently studies being done. There have been some studies already published that kind of correlate the use of amniotic membrane with a reduction in anastomotic leak by up to about 80%. It's a massive, massive leak reduction, right? Each leak costs the hospital between $200,000 and $300,000. Length of stay increases from 5 to 32.5 days. The associated cost with that length of stay increases from average of $11,000 for your non-leak patient and per day, $11,000 per day over that 5-day stay. And it increases all the way up to $37,900 per day for your leak patient, right? ICU days increase from 0 up to 9. And your surgeon has a miserable, miserable experience with handling these patients, right? What leaks do not occur immediately. Most surgeons in the space, if you're doing an anastomosis, they know how to check for a leak, right? And before they leave the OR, every single one of your doctors should be checking for a leak. So it's not going to happen immediately, but by day about 3 is when these leaks are going to start occurring. Your doctor is going to start getting calls at 2 a.m. from the patient bitching and moaning about flu-like symptoms, and that is a disaster phone call for your provider. So by utilizing an amniotic membrane, reducing the anastomotic leak rate by up to 80%, you're going to save the hospital $200,000 per patient. You're going to drastically improve your surgeon's satisfaction and lifestyle, right? He's no longer going to be coming back to the hospital to treat flu-like symptoms at 3 a.m. And you're going to drastically free up both operative and inpatient hospital beds, right? So there's a very, very, very large financial incentive to the facilities to want to reduce these anastomotic leaks. Okay, so that's kind of the big 30,000-foot view of colorectal. Guys have questions?
No.
No, that's
Okay.
good. Hey, let me ask you this, Jerry. So Malcolm, and again, so Cindy being in the DoD VA, obviously insurance doesn't play a big part because they're TRICARE and they do their own thing. So right now, kind of bridging off what you're doing, I'm starting to get more and more specialties right now using it surgically outside the DoD and VA. From my understanding, there is a national CPT code, right, that they can put down that they get reimbursed. So again, it's great for the patient. It's easy for the doctor. And by the way, it's going to be pretty much somewhat reimbursed to the hospital. Do I understand that right?
Yes.
Okay. So Malcolm, that would be a great selling point for you as well. So again, I'm all over the place, but like you, Jared, Malcolm is really, really great friends with all the top spine guys and the traumatologists. This guy that he's helping or is helping him get in, he is a major trauma guy. Do you mind sharing with Malcolm trauma-wise where these guys could use that surgically?
Yeah, it's a great question. Great question. That was where my introduction to amnion was actually in the ortho trauma space.
Yeah, that's exactly. One guy is going to link into 3 guys. They all do the exact same thing, or best buddies.
Yeah.
Hey, Jerry, before we move on to trauma, can I ask a real quick question regarding the leak? You said it was an 80% reduction. Is there a clinical paper evidence or something in case that's asked?
There is, just not branded by you guys.
Okay.
I'd be happy to share that with you. I just don't think that you'd
No,
want to.
I was just curious if that.
Yeah, I mean, it's out there. Yep, you can
Okay.
absolutely find it. And I have no issue sharing that white paper with you. It's just, it's got the actual product name on it.
Yeah, I got you. Cool, thanks.
Yep. Yeah, and that's, yeah, I mean, we're heavily exploring that right now. The results are ridiculous. Yeah, so Malcolm, let's go back to trauma real quick. All right.
Hey,
So
I have one quick question where I don't forget. Make a note of it if you don't mind, and we can get back to it. Do we have any competitive data to New Shield at all?
So what you're going to realize and notice in the amniotic space is there's not a whole lot of competitive data against any products. There's some articles currently being authored in the wound care space comparing Q-coated wound care allografts, but really when you start talking surgical amnion, and when you talk amnion in general, right, because it's controlled under 361 and it's minimally manipulated, right? Clinical studies are not required. It's, you know, from a business perspective, right? Why would you invest the money into developing clinical data if it's not required? So you're not going to find any competitive analysis really of your product versus New Shield versus Pure Apply versus AmnioFix. It's not there. Now, what I'll say is, you know, our teams from the manufacturing side, you know, we definitely we have created some of those competitive advantage sales sheets. So I think that's something that Mike and Tim might have some interest
Beautiful.
in helping.
Beautiful.
And guys, I could help you out if you need some help with that one. Pretty straightforward, but okay.
Yeah, guys, we can talk about some of the stuff Jerry's alluding to in colorectal. One of my closest friends owns a sister company. His name's Mike, and he owns a company also based in San Antonio called Evologics, and they have a patch specifically designed for colorectal, and it's just an amnion patch with a hole cut in the middle of it. So, it's in my mind, it's that is not necessary. It's kind of a nice thing, but we're working on a tool where we're gonna let you guys cut a hole in our patch on the field instead of to get around the patent. Jerry can, but anyway, that's what Jerry's alluding to. They'll be the first ones to research amnion in the colorectal space, which is cool. And it will help all amnion companies like us as well. But you guys have access, if you have colorectal doctors, again, the owner of that company and one of Jerry's partners is one of my closest friends. So you guys would have access to sell that product too if it's needed in colorectal. Yeah.
Yeah. Cool.
Yeah.
All right, shifting back to trauma, and then we're coming back to general surgery. So just quickly, you know, Malcolm, I mean, you being in both the spine and the trauma space, I'm sure this is all going to resonate really quickly, right? Where I have used amnion and where we've seen a lot of our providers opt to use it routinely are during hardware coverage, right? So you think ankle fracture in the younger patient that's going to get quick bony on and ingrowth too, right? So you're trying to prevent that for the explant down the road. See a lot in nerve repair, or maybe not even nerve repair, but nerve inflammation reduction, right? So again, if you look at the ankle, if you look at the proximal humerus, right, with your radial nerve, if there's trauma done to that nerve, right, and it doesn't have to be completely ruptured, it doesn't have to be completely torn, it doesn't even have to be partially torn, right? But proximal humeral fracture, right, big oblique spiral fracture that whacks on the radial nerve, you know, prior to ORIF, that nerve's gonna be really pissed off. Patient's not going to have ideal function until that nerve calms down and the inflammation resides, right? So amnion in that space will serve as an anti-inflammatory and as an early wound healing device, right? So when we're talking amnion, in general, we're talking wounds, right? Whether they're traumatically induced wounds or they're chronic non-healing wounds, right? But regardless, we're always talking about an injury, always talking about a wound. So, right, if that nerve's getting damaged in any way, by using amniotic membrane, you're providing an anti-inflammatory device. You're going to assist with the recovery of that nerve, right? So if there is some damage to it, you're going to help with regenerating that nerve tissue. The only situation where you don't want to use amnion in a nerve setting is with a complete rupture. It does not have the capability to reconnect a nerve. It does have the ability to help with regeneration of a partially disturbed nerve and also with assisting the inflammation residing, right? So that's a big thing in the nerve space. Hardware coverage, absolutely. We've got so many docs that believe amnion in all of their total arthroplasty procedures is almost required, right? With the rise in incidence of periprosthetic fractures and with the rise in incidence of periprosthetic joint infection, there's a lot of benefits to having amnion either directly on top of the hardware or during the muscle fascial layer during closure. I mean, we've got I can think of 9 guys right off the top of my head that literally put a patch on every single total knee and total hip they do. They swear by it. They'll never change course. So I think that's definitely from an ortho perspective, right, Malcolm? If you're dealing with any kind of arthroplasty, disasterplasty surgeons that are dealing with these bad periprosthetics or dealing with the bad osteomyelitic cases, that's definitely a nice target for you. But really, trauma space, hardware coverage, the anti-inflammatory and wound healing effects. Obviously, you've got it. If you have an open fracture with some tissue loss, with some bone loss, something that needs a flap or anything like that, there's an application for amnion as well to assist in that healing.
There, you're talking about the totals, man. You're talking about the knees and the hips. So
Yes, sir.
tell me exactly when and where you put that on, because we all have great relationships. That would be a good selling point.
Yeah, so it'll always be placed at the very end of the case, right? So I can't tell you why some docs place it directly on the implant versus some place it in that musculature layer, right? I've had that conversation with a bunch of guys, and every single time I have it, I'm like, I leave there and I'm just like,
No, I'm with you, man.
okay. Their thoughts with it are twofold. One, it's going to assist with the early tissue regeneration, right? I mean, the biggest thing with any kind of arthroplasty patient is getting them back to activity as quickly as possible, so all the other functions are left undisturbed, right? So early return to activity, which we're going to talk about in GYN in a minute because it's actually substantiated, and then protecting in the event of reoperation. And that is, in an orthopedist's mind, I mean, there is so much data coming out almost daily in the periprosthetic fracture and periprosthetic joint infection world that I think is really pushing a lot of these guys to ensure that they can get back into the exposed site as quickly as possible, right? Because we're talking periprosthetic, we're talking about an elderly patient population. As they get older, comorbidities increase, right? So if there are a bunch of adhesions that form during that closure of the musculature layer, or if there's adhesions that form directly onto the implant, that's going to make it incredibly more difficult for the surgeon to actually expose that site, right? Increasing operative time. So I think twofold, right? Helping patient return to activity quicker, and it is reducing the incidence of mortality for future injury. And I think a lot of surgeons are starting to shift their mindset of not right now, not the next 5 years, but what happens when this patient falls apart, because now I've seen it 50 times in my practice and I know it's going to happen again. Does that make sense?
Yeah, no, perfect.
Cool.
So Malcolm has the relationships kind of like, look, man, they're willing, like we're Team Malcolm Britt camp, and they're willing to put this stuff anywhere. Once they get it in, he's going to be off to the races. But for him to have those clinical benefits, just like you said, are great. But to be able to specifically tell him where, so nerves inside the capsule, post capsule. Malcolm, is there anything else you have questions? And I want to bridge off that. Cindy is literally best friends with a spine guy who just left the military to go civilian. She has a big meeting tomorrow. And again, I keep adding stuff on the plate, but if you can talk to her about spine, right? Yeah. I know we're doing laminectomies right now, major decompressions, A-lifts, O-lifts, all that jazz. But also, and again, just write it down for the past thing. She needs to know a little bit about the fibers, Tim, right? She wants to be able to push the fibers, on the bone graft side.
Well, let me just hit on the fibers real quick. Okay. Cortical fibers, there are many studies out there, not by anyone on this call, but there are plenty of studies out there published by like the MTFs and LifeNets of the world. The cortical fibers are some of the easiest DBM products for union. Okay, so they have some of the highest union rates. The pushback that you're going to get from fibers is that many guys that will switch to fibers are coming from a viable cell product. Okay, that means a cryopreserved product that companies market as a living cell variant. It's not true. These types of products are called Strikers is Bio4, Depusynthes is Vivigen, Medtronic, and a bunch of other Medtronic, Orthofix, a bunch of other companies have distribution rights for a product called Trinity Elite. Those are all quote unquote viable cell products. those viable cell products are not actually viable cells. There's been plenty of studies done in the last 36 months showing that those cryopreserved living cells are not actually living in any way, shape, or form, right? But these are very, very, very high cost products. You know, Vivigen, I just had a meeting yesterday for a Vivigen account. For 10 cc's of Vivigen, they're billing at $3,950. It's absolutely
Ooh.
insane. You can accomplish the same exact thing that you're getting through Vivigen or Bio4 or Trinity by utilizing cortical fibers, which have osteoinductive and osteoconductive properties already with it. And you can make them osteogenic by adding the patient's own blood to your cortical fibers. So on the back table, right, and these are going to come hard. They're going to require some kind of hydration anyway. If you utilize the patient's own blood and the patient, you know, relatively healthy, you know, if you take a 90-year-old diabetic, oncological patient's blood, it's not going to do absolutely anything, right? So it's all kind of perspective, right? But in general, if you mix the patient's blood with cortical fibers, you're going to get the osteogenic, osteoinductive, and osteoconductive properties that make these living cell variants so popular.
Yeah, and the work and what we do is we'll just draw BMA out of the hip if it's a spine, and we'll add the BMA with plus or minus concentrating it. Like half the guys concentrated, half of them don't, but they'll just use bone marrow from the hip or wherever they can draw it. Trauma surgeons will draw bone marrow from a number of different places. So wherever you get it, you just use that instead of saline to hydrate the fibers, and you have the same thing, probably a better product than what comes frozen in the, if you know, from Trinity or any of these other frozen allografts.
And even in that setting where you harvest the BMA in conjunction with your cortical fibers, your cost to the hospital is still going to be half, if not even less, right? So massive cost savings opportunity there. Cortical fibers have, I mean, they're freaking phenomenal as a structural allograft, right? So if you're thinking inner bodies, anything like that, if you can convince a surgeon to ram that shit in there, the union rates are going to increase. I mean, we've seen that. So in the spine space, they're talking amnion. I think, and Tim, you know, you're kind of the expert in the spine space. I've dabbled in it, but I think the spine space even makes more sense than the arthroplasty space to be using amnion during every single closure, right? I mean, when you think about the incidence of adjacent segment disorder in the spine space, and the, you know, the
let me
reoperation of that.
Yeah, so we use amnion to cover the nerves after decompression. We use it to on A-lifts so that if they have to go back in the front, there's a clear tissue plane. We use it on ACDFs for the same reason, clear tissue plane, lay it over the plate so they can get back in there when they have to do an adjacent level. So nerve root decompressions, posterior cervical to lay over the spinal cord, anywhere where you want to wrap a nerve, you know, to an irritated nerve or a space that you might have to come back in later, do a T-lift after decompression a couple of years later. And we've had a lot of surgeons that were like, no, I'm not going to use amnion, but they'll try it, and then they go back in on a revision surgery, and then they're believers. They're like, yeah, we're going to use this on every laminectomy, every decompression, A-lifts, ACDF. So we use it a lot in spine.
Good.
Again, those reoperations, right? Those revision cases are, every surgeon hates those revision cases. So anything to expedite those, help with exposure, etc. All right. Any more questions on ortho before we shift back to Euro? And
I think we're good.
all right, cool. So colorectal, you know, the anastomotic leaks, those are going to be, you know, the big things that you're focused on. In the urology space, and the timing of this call was awesome because I was texting with one of our urologists, one of our newest urologists last night, and I got some feedback I could share with you. So in the urology space, one of the biggest problems for urological surgeons is return to continence and return to impotence in the post-radical prostatectomy space, right? So they're going in for prostate cancer, they're doing a full resection, they are making an anastomosis, right? So they're resecting something, reconnecting something, they're making an anastomosis. But there's 3 different nerve bundles. There's a nerve bundle that runs on the urethra, and then there's a nerve bundle that runs on both sides of the prostate. And there's no way for a urological surgeon to do their dissection or remove the prostate without interfering with those nerves. And what we know is fact is because of those nerves being damaged, it takes an incredible amount of time for these men to form an erection and to be able to urinate on their own without a catheter, right? Typically, it takes about 120 days, and there are many clinical studies proving this. So it's not just me making stuff up. Take about 120 days for a man to return to continence without leaking, right? So 120 days before you'd be able to hold your bladder again with, you'd be peeing your pants up with it. Erections are even more insane. It could take up to 9 months for a patient to reform a natural erection post-radical prostatectomy. We've been doing cases in the urology space for about a year now. We don't have a ton of cases under our belt, but we're starting to really build them up. And what we've seen, and we're writing this up currently, but what we've seen is that we're able to return some patients to continence and impotence within 15 days.
Wow.
So I was texting with one of our newest urologists last night. He did his first radical prostatectomy 13 days ago today, and saw his patient first day post-op yesterday. The patient had his catheter removed day 5, and by day 9 was able to hold his bladder.
Wow.
So what is that, Jerry? That's a 2x3, 4x6? What do you think?
Yep. So what you're going to do on both nerve bundles on the sides, right? So on the sides of the prostate, it's going to be 4x4s.
Mhm.
And then your urethra, it's going to be a 4x8. Okay. So a longitudinal 4x8 on the urethra.
Yeah.
And then what it looks like with the 4x4s is it's actually going to be kind of like held up onto the wall.
Okay.
So it's not actually wrapping a nerve, but the nerves they're in a bundle attached to the wall. So you're going to place it there. So you're going to have 2 4x4s on the walls and then one long 4x8 wrapping the urethra.
Got it.
Yeah, so it's a very high ROI case for you guys, right? I mean, you're getting 3 patches out of it. But from a clinical standpoint, I mean, it could be one of the most remarkable spaces to use it. There's just not enough data yet. But anecdotally, we have quite a few stories like that where we're returning patients to continence. About 30 to 40 days is what we're typically seeing.
If Cindy had a urologist or Malcolm had a urologist that wanted to talk to a colleague, do you have somebody do you have a peer-to-peer? Do you have a peer-to-peer option, like somebody that could say, hey, I've tried it this many times and this is what I kind of feel like it's doing or not doing?
Yeah.
Okay.
Yeah, our meeting in urology went really great. We had good participation. They seemed very interested, and we just haven't had any bites yet. So I'd love to revisit the department and kind of present that.
Yeah, and
Speak to
urology
that.
is a space. Most of the time when you speak to them and you start talking about that anecdotal evidence, you're going to get some major eyebrow raises. Like, these guys
Mhm.
really love it.
Yeah.
But you're right. Like, the thing with radical prostatectomies is this is not an everyday procedure. A really, really, really busy surgeon is going to do about 150 of these a year. So it's not going to be, and that's literally top 5 percentile, right? Your average urologist that's doing these, because not every urologist is going to do these. Your average urologist that's doing these is going to do between 40 and 60 a year. So I wouldn't feel discouraged that you haven't heard from those urologists yet. It could very much be on their mind. And they're just searching for that first patient. What I would say though, is in any situation like that, you do not want that to go idle.
Right.
So to Tim's point, this might be a great opportunity to kind of revisit. Hey, you guys want to speak with a KOL, with a colleague, that's doing these in these spaces and seeing awesome results. Maybe it's something, I don't know if there's a residency program involved or anything like that, but journal clubs are a very uncostly and effective method to kind of get you really intertwined with the entire program. So there's definitely a few different ways to go about that, but I would not let it go idle. I would take back the story I just told you. I would take that right back to whoever that lead urologist is at that clinic and just say, hey, you know, there's no clinical data yet. This is what we're seeing anecdotally. We have somebody writing it up. Why don't we give it a
I
shot?
will. And that's good information. And you're right about the residency programs. And we just started our ortho program, but we have residencies in all services at WOMAC. So that would be good.
Yeah, journal clubs. Tim, I know Tim will support you on this. They're very, very uncostly and they're so impactful, right? If you do get a surgeon out of that's now pushing your amnion during every one of these, every single one of those residents leaving that program is going to be doing this for their radicals moving forward, right?
Mhm.
So love those situations. They're a ton of fun and they more often than not really pay out.
Okay.
So in the GYN space, so the GYN space, I'll tell you, is your number one volume procedure. You know, you guys, if you want to spend your time on what's going to yield the highest number of cases, the OBGYN space is where you want to spend time. Because the applications for amnion in the GYN space are pretty vast. So hysterectomies, endometrioses, cystectomies, myomectomies, C-sections even, are all applicable spaces for amnion. The question in the GYN space is why? What's the outcome that we're looking for, right? Because if you think about a hysterectomy, what are the problems? Bleeding, bloat, postoperative recovery, pain, etc. You know, return to normal activity. If you think about a hysterectomy, that surgeon is causing a ton of traumatic damage. And everywhere where they're making that cut, you know, most of the time through cautery, but you're going to have some serious adhesions form around all of that damaged tissue, right? So where you're going to see where you want to push for your amnion to be used in a surgical setting is going to be on that vaginal cuff post-hysterectomy, right? If adhesions form on that vaginal cuff and if they form on that vaginal cuff, what you're going to see are patients, instead of being this way, they're going to be buckled over just slightly. And I've seen this quite a few times with, I have a very large KOL down in the valley, or down in the Rio Grande Valley of Texas, that, you know, we kind of started doing this together. We started looking at it from a few different ways. And that was one of the biggest issues that he saw from a presentation perspective, is the adhesions can be so bad that patient can't even stand all the way up, right? So in the hysterectomy space, preventing adhesions is your number one goal. Number two is reductions in postoperative pain and bleeding, right? So what we've seen after the implementation of EvoPatch onto the vaginal cuff is drastic reductions in postoperative pain, drastic reductions in postoperative bleeding, and early return to activity, right? So depending on your surgeon, your patient might stay one night overnight. Typically, those are outpatient procedures, but they're really not supposed to have any kind of activity for 7 to 10 days post-op. And just like an orthotrauma case or just like a spine case where your patient's not getting back up on their feet real quickly, right? There's gonna be some stiffness that forms. There's gonna be some adhesions that are already begin to form within that period of time. So by that 7 to 10 days, they're getting up and now they're in excruciating amount of pain. They're not having the same level of activity as they had preoperatively, right? So what we've seen is by utilizing EvoPatch, or by utilizing an amniotic product, we are reducing postoperative bleeding, reducing postoperative pain, and returning patients to activity within about 3 days post-op.
Dude, this is good, Jerry. So give me a size, brother. What do I use? What do you
Every
recommend?
time, 4x8.
4x8. Okay.
Every time. Yep.
All right.
Okay, so now looking at endometriosis. Looking at endometriosis. Endometriosis impacts about 11 million women a year. Pretty much just like systemic formation around the placental region, around the vaginal cuff, etc. When you're removing those, and typically in endometriosis, you're not talking about like 1, 2, 3 cysts. You're talking about 15, 20 cysts, right? So this is typically a staged procedure where your surgeon will go in and remove about 50% of the cysts initially. And again, we're thinking through it, right? If we're resecting any kind of tissue, adhesions are going to form. And with these cystectomy cases, with these endometriosis cases, there are so many cysts that those adhesions will literally grow onto other adhesions, right? So Now you have fertility issues. Endo typically ends in a patient not being fertile. You have the pain and activity lifestyle issues from the adhesion formation. And the cool thing about the endometriosis space is you typically revisit the patient operatively about 8 weeks down the road, right? Because what your surgeon's not going to do is he's not going to keep the patient in the OR for 4 hours while he removes every single cyst. It's not right to the patient. It's not safe for the patient. So they'll stage this. And the really cool thing is, because we're staging these procedures, right? You guys are going to be placing 2x2s or 4x4s on every single one of those cysts. So 8 weeks down the road, when you guys come back, you're going to see the tissue re-epithelialize. And it's a really, really cool experience seeing it, because all you see is this red, really healthy tissue without any kind of scarring formation anywhere around it, right? So we can visualize that. So we're also looking into that, because you can visualize these things. And what I'll tell you is, quite a few of our GYNs that are using this routinely for endometriosis believe there's an impact that it has on fertility. Very anecdotal, very much up in the air, but it's something very interesting that as you're having these conversations with GYNs, it may come up, and there might be something there.
How about cesareans?
Yeah. So C-sections, I think make all the sense in the world for amnion, right?
Yeah.
Your problem, just adhesion formation, right? I mean, especially in your primary C-section patient, you know, the statistics are 83% of women who have a primary C-section for their firstborn will have an additional C-section, right? So that's one of those cases where, hey man, 83 out of 100 times, you're going to have issues revisiting this patient. Why aren't we using it? Now, from a reimbursement perspective and a cost perspective, I would advise you to be very careful with cesarean section marketing and sales, because more often than not, these cesarean sections are not being done in the traditional OR, right? So they're billed out at a very different rate through L&D. And we've definitely had it many times where we've literally gotten calls from the hospital. What are your reps doing in L&D? So I would caution you there. I think what's needed in the C-section space is clinical data to support reimbursement, but it's not there right now. But there's absolutely clinical applications there. I would just be cautious about pissing off your hospitals with them.
All right, so time out. Can Miss Cindy, she can go DOD VA, not worry about a damn thing, right? But us in civilian, Malcolm and I in civilian, I hear what you're saying about coverage in L&D. Is that right?
Yeah.
Okay.
Yeah, and you know, the crappy thing there is how many C-section deliveries are being done at the VA.
Yeah. Well, no, I'm sorry. At the
Well, in the DOD, there's a
yeah,
ton.
sorry. We got problems if it's at the VA. Yeah, at the DOD
Yeah.
at Womack.
All right. You guys have, does all that make sense in the GYN space? Do you have any questions?
Yeah,
No,
listen,
that was great.
dude, you've been great. I know we're coming up on the 1 hour, man. I want to get, it's Friday. I mean, Thursday, get you guys out. But
Yeah.
Malcolm, is there anything you have, man? I know you're going strong. I mean, just having Jerry and Tim, these guys on, is there anything that you really need to help you get over that hump?
I think I'm covered. It's just more of a competitive play, showing my advantages over a New Shield right now. Because that's what they have
That's
in.
your single biggest kind of hurdle to jump.
Yes, because we have a separate ortho hospital that they have that in stock. So
So
That was
Malcolm,
our
I would
point
pick
for
one. I would pick one or two of those guys, and and speak to Jerry's talking points that you think that this will crumble less and it'll be easier to handle and it'll be better with their gloves. And let me send you a couple of trial grafts to get them to try it. Just say, look, don't take my word for it. Let's do a case. And if you need to give them the graft, I'll supply you the graft, but let's get them to trial it and show them what you're talking about.
this guy alone does, he's not going to use it for everything, but just where you can understand, he probably does 20 plus cases a week, and his partners and him have a great relationship. There's 3 of them, and they are 2 of them every day of the week.
So you
6 to 8
comfortable
cases
with
a piece.
that? You comfortable with that strategy? If they won't buy a
100%.
we'll give them a couple grafts and let them see the difference.
100%.
Okay.
Hey, I'm embarrassed to tell you, man. I used to work and distribute for Organogenesis a while back, and I'm the one that got the new cell in, right? And the pure apply. Remind me though, Jerry, is the Organogenesis product the new cell product? Not the new cell, but what we're talking about. Is that dual layered or is that single? Because I remember there were always some finicky issues with one of them.
I don't think it's.
I think it's dual.
Is it?
Isn't that new cell? We just, hold on, we're gonna look it up again. We had it pulled up to. New Shield is,
New cell. New cell is the stem cell, yeah.
New
Yeah,
Shield
it's
is.
dental tissue, not amniotic.
No, you scroll up, not down. Is there no?
So it's an amnion chorion product.
Mm,
Yep. So yes, I mean this is exactly what we're talking about. It's a amnion chorion product that they pump a little bit of hyaluronic acid into. So again, that thing is going to handle just like AmnioFix. I believe New Shield's actually a little bit thicker than AmnioFix, so it's a little bit more cumbersome in a minimally invasive setting. I have never seen New Shield used minimally invasive or robotically. So it makes sense that you're only talking at ortho trauma, but you know, when you're talking general surge, urology, GYN, I want to be worried about competing against that in those spaces. And again, the price point is going to be a big differentiator between New Shield and what you guys can offer.
So Malcolm, more plethora of specialties that can use it because of the handling, right? The price is going to be there, and your doctors, they know you and your customer service, brother. Those three, dude, go after that.
That the price point's going to be huge when they see it. Huge.
Cindy, what you got, Mama? You got anything else?
No, I mean, the spine stuff was super helpful. I'm really looking forward to that meeting tomorrow. I'm definitely not going to sleep on urology, so I'm going to present back to them. And then I'd really like to talk to Womack and some of the surgeons about Vivigen and kind of competing with the fibers on that because I have a hand surgeon that is using Vivigen.
Awesome. Yeah.
Yep.
Yeah.
Awesome opportunity there.
Good idea.
And hand
Look, I was going to say this.
not make much money for the hospitals, right? So if you can help the hospital reduce a hand surgeon spend through reduction in Vivigen, hospital's going to love you.
Yes, I'm excited about that. So that's where I'm going to start.
Jerry, this
thanks,
has been
brother,
great.
for
I
your
know we've
time.
been, dude, firing shots everywhere, but dude, this is stuff real world, obviously, that we need to know. We all have the relationships. Cindy, by far, out of my three, is 3 times smarter than all of us. Clinically, she's incredible. She just needs to learn how to push on these people that have promised her stuff. And now that she's a rep, they're like, oh, I'm a different person. But she has the relationships clinically. There's nobody better. Once she gets this going, as she is, dude, she's not gonna have enough hours in the day to do what you just explained. So this is good for her to
Man,
hear.
I hope you're right.
Fantastic.
Thanks, guys.
I'm pumped for you. Tim, feel free to share my contact. If you guys have any questions, let me know.
Yeah, thank you, guys. Talk to you soon.
Thank you so much.
All right.
Hey guys,
See you.
thank you.
See ya.
Have a good day.
All right, bye.